How did you decide to be an OBGYN? I don't think you've ever told me that story.
Well,
we've talked about the family planning part.
Yeah. So I feel like when you're in med school that people either are medical students who during their clinical rotations hate everything or like everything, like hate all the other specialties they see or like them. And I was sort of a like everything.
Yeah.
There were one or two where I realized, all right, this isn't a good fit for me. And from that, I realized, all right, well, I like doing some sort of surgery and I like seeing patients in the office. And I had done, we both speak Spanish, and I had done the Honduran Health Alliance, which you founded.
I helped fit. I wasn't the founder.
So I had traveled to Honduras and helped provide primary care and contraception to people in these remote villages, really, that didn't have other access to healthcare. And I think that the thing that I saw from that, which wasn't surprising, was that the role of contraception was just so important to people determining all sorts of control over their lives, and that they didn't have access to contraception in other ways. And so that was really an impactful firsthand experience, even though I understood from the data that was there. And then I really liked birth. I liked obstetrics. I had fun on the obstetric unit. I liked working with the nurses. I liked working in a team of doctors, and the sort of pattern and pace of being there, and the occasional, you have an occasional emergency or an occasional quick action. And that was fun to do that and to feel skilled in doing that. And then I knew when I went into residency that I wanted to be able to learn to do abortion, that was an important part of the training. And I sought out programs where I knew that I would get that training that was going to be excellent. My first memory of being conscious of abortion was driving past the Planned Parenthood in Chapel Hill and my mom screaming out the window of the car at the protesters, like counter-protesting the protesters while driving. And so I think it was just taken for granted that was something that was important and a part of my family, my values in my family, that was that people should have that right. And so I wanted to learn to do that. So I did OBGYN training and thought I would want to do general OBGYN and full scope and do gynecologic surgery and see people in the office and deliver babies, and perhaps do some abortion care. And then I'm someone who likes doing research and likes doing policy research, and a lot of my mentors and the research I was interested in were really family planning focused. And that was a good fit and a good way to get additional training in that, to be able to help people in that way. Bev, how long have you been doing abortions?
Since residency, so 2009.
Most of your career.
Yeah. And I think when I started providing care as a resident, I wasn't really sure what I wanted. Like once I decided OBGYN, I wasn't really sure what path I would take. And then pretty quickly decided that I still loved obstetrics. I loved all of general OBGYN. And then I had this opportunity to do this job that was part-time family planning, part-time just general OBGYN. And that was perfect for me. And I had a mentor that kind of trained me to do the work. And I think once you get into this field, you see how impactful your care can be. And, like a very short, you've talked about this before, you have like a short interaction with people and it can be life-changing for them.
Did you know when you went into OBGYN, were you interested in doing abortion, or did you know that was going to be part of the training?
Yes, I definitely knew it was going to be part of the training. And I think, how I actually had, you have to write a personal statement when you apply for residency. And I actually had two different personal statements. I had an East Coast statement and a West Coast statement. And my West Coast statement talked about just kind of my family and, growing up in Southern Baptist Church, but having a grandmother who had had an abortion that had saved her life. And I felt like at the time, I don't know, I really didn't know what I didn't know what I was doing. Sometimes I still feel like I don't know what I'm doing. But at the time, I felt like it was okay to share that with the West Coast programs, but maybe not the East Coast programs. Mm-hmm. But I remember having this discussion with my dad, who's, he's still, deeply religious, deacon in the church. And we sat down before I was interviewing for residency, and I said, this part of this work will be providing abortion care. And that's when the story about my grandmother needing an abortion to save her life came out. And he was like, yeah, you need good doctors that provide this care.
Do you want to tell that story on the podcast? You've been
I haven't been telling that story as much lately, but sure. My dad's mom in the early 70s before Roe experienced two surprising health diagnoses. So she was in her early 40s and was diagnosed with cervical cancer and an early pregnancy at the same time. And at the time, North Carolina was one of a few states where you could have abortion care for medical necessity. And so she had a hysterectomy that ended her pregnancy, but also cured her cancer and saved her life. And she was a very important person for me growing up. Like, we spent a lot of time at our grandparents' house, and, she was feisty redhead, sort of like myself, and was an important person for me and who I became and helping kind of frame my values and kind of what I care about.
Was it a story she told? I'm just curious.
No, I didn't know about it until after she died. Do you think if you could go back, you would do it all the same?
I think about the counterfactuals of what other medical specialties might have been right, or even subspecialties within OBGYN. I'm happy with being an expert about the things I'm an expert in, or being able to, certainly the patient interactions. I think there's no other type of medicine that is similarly rewarding because of the way that you get to meet patients, help them, and the ways in which you get to do that. It's so, as you just said, right? You can spend 5 minutes with someone and change their life, and there's just no other, and have them be grateful for you doing that service. And I just don't know of any other type of medicine where that is the case.
All right, here we go. On my way to clinic.
With the shifts in law in North Carolina, we have both gotten a medical license in Virginia and are now providing care in Virginia, where, we travel to a clinic that's about 2.5 hours away from here. I tend to do it in one day. Like, I leave very early in the morning, get back late at night. I kind of like driving.
I kind of hate the restrictions in North Carolina. Make it really grating for me often when I'm providing care, because I feel like I spend so much time worrying about the paperwork and the check boxes that it takes me away from being able to interact with the patient, and takes me away from feeling like I'm doing the work that I'm supposed to do, or being a doctor. So I'm really grateful that we've had the opportunity to practice in Virginia, because I get to feel like a doctor again. I get to feel like I'm using my skills and doing the work that I know how to do, as opposed to doing paperwork.
So this woman stands between the bushes.
It's so weird. So now there's next to the clinic that we go to, there's a crisis pregnancy center. So, a center next door that's trying to divert people and catch them before they get to the clinic. So people go into a room that looks like an exam room, and they meet with someone who is wearing scrubs or wearing a white coat, who looks like they might be a doctor or a nurse or an ultrasonographer. And then that person often will perform an ultrasound. When I get on a plane and I see someone in a pilot's uniform, I don't think to ask whether that person has a license. And that's what's going on here, right? You're you're going into something that you believe is a clinic, and you're getting a service that you expect to receive at a clinic. And it is not from a person, it's not from a medical professional necessarily. Now, from the patients that I've talked to and from public accounts, the nature of the ultrasound is different. And they will often force people to look at the ultrasound, say your baby is waving at you, call the person mommy, even people who are, open about the fact that they're seeking an abortion. They will, often share their own religious philosophy or ask people to pray with them. And it's very, very deceptive for people, and particularly when it has a name that sounds like it might be a clinic that provides abortion, but in fact they would, maybe do an ultrasound and then try to talk you out of an abortion there. And then there's this line of protesters, sort of trying to give you pamphlets or have these posters as you drive up in your car or yelling at you.
The woman with the microphone is there. Tried to stop me on my way in, but with brochures. There's no one up front.
And then the particularly charming feature, I think, at this particular clinic is that protester who stands in between the bushes and talks with a megaphone, right?
Yeah, they're like, yeah, no, I think the last time I was up there, one of the things they were yelling, which was, I mean, it's always fascinating, and they're not always yelling. It's sometimes
well, they have a megaphone, so they don't have to yell,
right, right. But last time they were saying something like, there's a heartbeat as soon as you have a positive pregnancy test, and I was like, oh, that's new. That's not in the medical textbooks. So I think this false lie about the heartbeat when you have a positive pregnancy test is it's dangerous because there's not a heartbeat at that point.
And the reason it's not a heartbeat is because the heart, a 4-chambered heart pumping blood, doesn't form until later in pregnancy. Right.
There's this powerful imagery that we have of a heart and a heartbeat and having that connected to hopes and dreams and aspirations. That can be very powerful.
Yeah. And let's talk a little bit about embryology. Early on in embryonic development, the structures that will form the heart begin to develop. And those early structures are these cells, which create first a cardiac crescent and then form a heart tube. And then I do remember the embryology professor doing this complicated thing with her hands and twisting to sort of show how a tube becomes a 4-chambered heart over time. When we see that electric signal, that flicker on the early ultrasound, what we're seeing are either those cells or that tube transmitting an electric impulse, but not the same thing as a pumping heart, which is what you and I rely on to move blood around our bodies.
Right.
I tripped. Are you okay? Yes.
Donnie, any help in here?
No, we're about done. Well, I just got the bed.
You need me to wipe it off at all?
Yep. Sure. Thank you. Just setting up some instruments.
So what's it look like when you walk into clinic?
Yeah, I mean, there are a bunch of people waiting in the waiting room. The people at the front desk are always excited to see us. Yeah, I mean, it looks like, sort of any other doctor's office. I mean, it's brightly painted. There are lots of signs welcoming people of, all different backgrounds and languages.
A little more security glass than in another type of clinic that you might go into.
Yeah.
And then you walk past a bunch of rooms that look just like another clinic, right? There's an autoclave or a machine to, sterilize instruments. There are laboratory machines. There's one of those chairs with the funny arms so you can get your labs drawn.
Mm-hmm. Yeah, ultrasound rooms. There's a big board where we have there's someone who's managing kind of the flow of the clinic every day. And so, there are these little magnets, and each magnet represents a patient that has a number. And we know where they're at in the counseling process, or if they've been pre-medicated, or if they need an IV, and do they want a procedure, do they want medication? And so you can go to this board and sort of get a sense, okay, this is where we're at. This patient's going to be next. And, kind of get a sense of what the day is going to bring. And you can kind of troubleshoot and be like, okay, well, this patient drove from a long way. They need to be pre-medicated. Let's think about kind of bumping them up, or, so you're trying to troubleshoot those things in the moment.
And oftentimes there's a couple patients who are already in the recovery room and preparation room, talking to the nurse and getting ready for procedures, and the staff is setting up the procedure rooms. And so you hear a clink of instruments and sort of know that, either both procedure rooms or one procedure room are going to be ready.
All right, how many patients we got left?
5 surgicals and about 2 maps.
Okay. All right. Any difficult cases so far? Except the one that Ashley Tracy had?
Because I wasn't in the room, but other than that, no.
Okay. All right. Thank you.
Yeah.
And so usually I'll walk into the procedure room. I have the patient's chart. I'll verify their name, date of birth, go over, review their medical history. If they're getting sedation, do a sedation exam. And just talk to them about kind of where they came from, who their support people are, if they have any questions or preferences. I like to play music at all times in every aspect of my life. So I have like the spa playlist that I pull up. And if I don't have it pulled, actually the nurses now know that I like spa music, so they'll have it pulled up for me. And so if a patient's getting sedation, you have a sedation nurse. You have another person there who may be doing ultrasound or just there as a patient support person. Sometimes the patient's partner will be there, or their mom or their sister or their best friend, like whoever their support person is, if they want them in the room. And I think that's one of the advantages of working in a clinic like ours that we have here, but also this clinic, is that people can have like someone there with them to help them through the procedure if that's what they want, which I think is always beneficial.
Yeah, I think it's nice not to be alone.
Yeah. Procedure takes about 5 to 10 minutes. And then, patient will go to the recovery room. We'll get the room ready for the next person. And, it's a busy day. Like you're zipping around kind of like interacting with lots of different teams of people, the nurses, it's a rewarding process.
Yeah. And there's a couple different types of people or different types of workers who work alongside us. And that's part of why the day is different there than it would be at a clinic where you're just seeing a nurse practitioner or you're just seeing a doctor for your visit. The patients have patient education, where they talk about the risks of a procedure, the benefits of a procedure, make sure that they have gone through all the screenings, that we understand their medical history, that they understand and have signed consents for whatever they're there for. And then, at some point they have an ultrasound, usually, I guess, before that patient education. Yeah. And then they see the provider to do a procedure or have a medication abortion.
Yeah.
How are we doing today, though?
It's going great, I think. Flow's been well.
Yeah. Are we almost done?
Mm-hmm. Yeah.
Is that a lie?
A little bit of one. Maybe like, I would say 2 hours. Yeah, 2 hours, 15 minutes maybe.
Okay.
And then I think we'll be good.
Do you have number 21 in your hand?
So Tamia's the health center manager.
How far along is she?
And she does a bunch of different things. So she's always pitching in to turn over rooms or do patient education or do ultrasound as needed, because she's trained in all of those roles. And then usually she's the one who is doing flow and making sure that the right patients are in the right place at the right time so that we can all move as efficiently as possible.
Right. I think one thing that makes her an effective leader is that she is not afraid to do whatever task needs to be done to get things moving on. And so that's one thing I appreciate about her. And just, she's part of what brings the joy to that clinic. Like she's
Absolutely.
A joyful person and clearly has like good bonded relationships with people.
Yeah. I mean, you can tell that people like love her as a family member or a deep, a friend, that she has deep relationships with everyone. But I also really respect about her that she will say no and tell you when you're out of line, including for us, or including for me for sure.
I try not to get in trouble.
Yeah, well, you're doing better than I am. And, it's also, she's just a really warm person. She's a mom and, always is showing pictures of her kids and telling stories about her kids. And so it's always fun to be there. And because we go once a month, right, little kids have big changes. And so you get to check in and hear about those. And that's always exciting.
Yeah.
How long have you worked here?
5.5 years.
Things have really changed in the past couple of years here, huh? Mm-hmm. What were the services like before?
There didn't exist. The no-show rate was really, really high. We would maybe see 10 to 15 patients on an AB day.
And now what's it like?
It's, we have our days where it's a little challenging with trying to service all the patients that we are trying to get to from various states. Most here recently that we've seen is from Florida. Florida is still high.
And we were talking about this earlier, that Georgia just changed its policy. But
and not everybody knows that.
Right, and so patients aren't able to be seen there yet.
Right. But they're all going up to like 20 weeks.
And one thing I always talk about is that even we see patients from North Carolina who could theoretically get care in North Carolina, but because of the 72-hour waiting period and the 2 visits there, they often will come here because it's easier for them to get care.
In Virginia, you do not have to have a consent. You just walk in and get an abortion.
Right, and they obviously have a consent for but they don't have to have like a institutional or state consent, right? Yeah, so it's better. So there was one patient today who was from North Carolina who wasn't going to get sedation, and not every patient gets sedation, but I feel like frequently you are scrambling to get patients a hotel room or a car. Why do you have to do that?
A lot of times patients are coming in here by themselves, and then each case is different, but a lot of them are needing IV sedation. And you have to have that driver in order to get IV sedation. So we're getting them an Uber with Uber Health.
Right, because they can't, after they get IV sedation, they can't go home, they can't drive themselves home. The other interesting thing is I feel like there's more cases at 14, 15, 16 weeks here than I've ever seen before in my career. And my thought about that is people are just pushed farther, right? It's so much harder for them to get there. And so that's the gestational age really where you're seeing that. Whereas before, there's other reasons that people need care in the second trimester, but it felt like it was spread more through the second trimester. What's the no-show rate approximately for patients? Like, because I feel like there will be a bunch of patients on the schedule, and then we don't always see all the patients.
Exactly. With Virginia being a no-consent state, like you don't need to do anything prior to the abortion. It's way easier to get in, so a lot of patients, they can push their appointment out, like if they have something to do. So the no-show rate is higher. Today, for example, we have 46 on the schedule and we've seen 30 patients, and we were able to see 2.
How many are on the schedule now per day?
Per day, we can fit 50. Today,
On the 2 provider days?
50 to 60 depending on the provider, and 46 scheduled today.
I'm Ashley Tracy. I'm a nurse practitioner, and I've been doing abortions for a long time. 10 years.
First and last name and your position?
Ashley Bradley and Health Clinic Coordinator.
It's confusing that there's 2 Ashleys, huh?
Oh, there's like 6 Ashleys.
6 Ashleys,
At one point there was 3 of us in one room with the patient.
So there's several Ashleys who work in the clinic. The one who I talked to on the tape is one of the nurse practitioners, and she provides abortion care throughout the day alongside you. And, when you have a question about how something's going to work, you ask one of the nurse practitioners.
In Virginia, you can, if you're a nurse practitioner, you can provide procedural care in the first trimester and medication abortion care.
And, it's really helpful to have, in any setting, it's really helpful to have another set of ears to bounce something off and to talk about a clinical scenario and say, hey, what would you do in this case? And so I feel like that is constantly sort of going back and forth in the room all day.
Yeah. It's like, look at this ultrasound, or what do you think of this case, or what would you do in this case? So it's great.
I'm printing off the med dispensing report, so that shows the patients who received medication abortions today, specifically tracking misoprostol dispensed in clinic. So we'll print that off. We'll have yourself and Ashley Tracy both sign off just stating that these patients were seen, did receive medication in clinic, and we'll compare that to the attestation where patients sign agreeing that they have the option to pick it up here in clinic, or they can pick it up at a pharmacy in the state of Virginia.
Medication abortion is accomplished through a combination of pills. So the first pill you take is mifepristone, and that blocks the pregnancy hormone and doesn't allow the pregnancy to grow into the uterus, and it gets the uterus ready to expel the pregnancy. And that's a highly regulated medicine and by the FDA, and is often administered in person by the clinician who's providing the medication abortion. And that's how we do it in this clinic, is you watch the patient swallow the pill. And then the second part of the medication abortion is misoprostol. And that's a medication that helps the uterus expel the pregnancy, or actually causes the uterus to contract and gets the uterus to expel the pregnancy. And you can get the patient that in a couple different ways. Patients don't take that at the same time as the mifepristone. They wait somewhere from 6 to 48 hours to take it. And so you can send it to a pharmacy, or if you're able to dispense it, meaning put a label on it and give it to the patient, then they can take it home from the clinic just as though they've gotten it from a pharmacy.
Right.
The process of dispensing it is complicated.
Yeah. And so we have to go through multiple steps for dispensing. We have to have a dispensing license. And the reason to dispense it rather than send it to the pharmacy is that we've had a lot of issues with pharmacies filling misoprostol, even for care that's not abortion care. So even for miscarriage care or for cervical preparation for a procedure like an IUD insertion, like sometimes patients need that for that procedure. And so there's some pharmacies that are making decisions about allowing patients to have this medication. So it's, if you want to make sure the patient has the medication, you dispense it yourself.
And right after the Dobbs decision, I remember in North Carolina, the law had not changed yet, but Walmart put out this national guideline to pharmacists saying that they needed particular confirmation about the indication for care if they were going to give out misoprostol. And that meant that our patients who were getting misoprostol, that medication for miscarriage care, would get to the Walmart, and then the pharmacist would say, well, I can't give this to you because the doctor didn't put the indication, or I can't trust the indication that they put on the medicine, and you need different confirmation from your doctor to get the medicine. And I mean, the cases that stand out most in my head are the patients who are non-English speaking and going to a Walmart pharmacy to get this medicine while they're having a miscarriage and are being told, oh, you can't have this medicine because I think you're having an abortion by some random pharmacist.
Yeah.
And it's just a misunderstanding of the law. There wasn't a change in the law. There wasn't anything that we were doing that was nefarious. There wasn't any risk to the pharmacy. It was just this misinterpretation that was nationally, distributed in Walmart's policy. And it's really hard to change.
Yeah.
When the overturn of Roe v. Wade happened, it was almost immediate that I was getting faxes saying, you are illegally prescribing miso. And they would put my name and my license number on these faxes. And they look like refills?
Yeah.
That's what it would come on. So I don't know if it was like an automated thing, but they refused to dispense it like the next day after Roe v. Wade overturned.
Even though the law hadn't changed here.
The law hadn't changed. And they didn't, it was a classic case of they didn't understand the law.
Right,
But
so it was fear.
It was fear-driven, and they tried to make me feel afraid as a clinician. So, of course, our immediate response was to go to our team of lawyers, and I was like, what does this, why are they threatening me?
Well, at worst, it's politically motivated and trying to restrict. And at best, which is still bad, it's such risk intolerance that they're willing to hurt people.
Now, I had a friend who texted me a couple weeks ago that was like, this is an OBGYN friend who went to a pharmacy to get Plan B, and they wouldn't give it to her because they felt like it was an abortion. This is a pharmacist who should know that emergency contraception is not an abortifacient, yet they were refusing to give it to them.
The patient, at the end of the day, the problem was the patients couldn't get their miso. So we had given them Miffy, and they couldn't get their miso. So that was what the reaction was.
So then we started dispensing the miso.
Well, then they came to me and said, hurry up and get online and get your limited dispensing pharmacy license. So I got it immediately because I do MABs every single day.
Right.
So they're like, you go first. And then all the MDs had to get in. That's why, do you remember sending your paperwork to me? I got it in my email. So then they're like, that's how we kept track of you guys getting your dispensing license as fast as possible. So in that time, I was cold calling pharmacies saying, hey, will you dispense it? Are you good with that?
And would any of them do it?
Yeah, the mom and pop shops will do it. Which is so funny because they're the ones who, I'd have no issues with my gender affirming stuff too. They're like, yeah, we'll order his tea or whatever. It was the small little town shops that were like, yeah, we'll do it.
I guess I'm curious about what the people opposing abortion think the end game is.
Yeah.
I think if anything, what we've seen in the half of states that now have restrictions is that people still get abortions there. Mm-hmm. And they just have to pay a lot more and work a lot harder and suffer a lot more to get them. And so abortion's not going away.
Right.
And the ways that have been proposed to regulate abortion don't help. Right. I mean, we know that they don't help from like a quality safety standpoint, but they also don't even achieve what they are setting out to achieve.
Right.
And,
I mean, since Dobbs, there have been more abortions in the U.S. in the year after Dobbs than the year before Dobbs. So it's not decreasing abortion in the U.S.
Right. And I'm worried that the new administration will mean that there is national legislation that regulates abortion in places that have seemed safe from a state standpoint, right? Because right now, most of the regulation is at the state level.
Right. But, I think, I don't know, it's really easy to get into a doom spiral about what will happen or what could happen, or just the endless possibilities of the ways that our patients will be made to suffer. However, there are hopeful things that we've seen out of this movement, and there is joy and beauty in this movement too. And the fact that there are new and creative ways that people can seek care and can still have abortion care even in restrictive places.
Yeah, and I don't think our jobs are going away.
No, I don't think so either. But they've changed, right? They've changed how we have to interact with patients, how we have to interact with the health system, how we have to interact with legislators. The job title has changed.
Yeah, and I think we're less hidden.
Mm-hmm.
This podcast is one way of being less hidden, but I think in mass, it's less hidden within health systems, right? It's in academic medical centers across the country that care for high-risk pregnancy patients. There are abortion providers. Right. And there have been for years, and that's nothing changed. That's a part of OBGYN care. And I think people understand that more now. And people who maybe didn't consider themselves abortion providers and were providing excellent care now have had to confront that, those regulations are part of what I deal with too.
Right. I've made the analogy that the positive things of this movement are similar to what is called trail magic. And so if you're a hiker, there's this idea that when you're facing a long hike, a strenuous hike, a horrible day of thunderstorms all day long, that you find this thing, this brightness on the trail, and that's the trail magic. And so for me, the people that I've gotten to know and work with, that's part of the trail magic.
It's so frustrating to hear other narratives and feel like people just aren't able to access the information. And I hope that what we've been able to do with this is put a bunch of information that we feel is important out there in a format that people can approach and take in little bites, so that if you're looking for an answer to a question about abortion, all right, well, I can listen to these people.
Yeah.
A lot of people have been important to helping us make this podcast, and it's a tremendous privilege that we've gotten to have our voices amplified in this way.
Yeah. So we're incredibly grateful to our donors that have donated both their time and money to supporting our show. And there's many people that fall into that category. But specifically, without philanthropy, we wouldn't be able to provide you this content in this unique way. And so we're grateful to those folks.
We also were incredibly fortunate to find a producer who was as excited and creative about this project as what we didn't know we needed in Jane Marie, and has supported the podcast sort of above and beyond what we would have expected or could have expected from a producer.
Yeah, so we're grateful to Jane Marie and Little Everywhere, her production company, that has helped make this the amazing show that we believe it is.
And part of Jane's trail magic is that she had a fantastic network who also cared about this cause. And so we got great music from Nick Thorburn and Patrick Ford and Maker. We're really grateful for that.
And we're grateful for friends who are artists. So shout out to Jamal Walton for original art. And if you haven't noticed, on our artwork, in the mask, you can see the silhouette of a person talking, And then on the scrub shirt, you can see a conversation bubble, which Jonas didn't realize that was part of the art until I pointed that out last week. So it's really cool.
I should have looked more closely. It's very cool.
Artists are pretty awesome. We'd like to thank our department, our employers. This work represents our own views, but we're able to provide this care and work in the spaces that we're able to work in because of a supportive environment.
Yeah, and we're grateful to all of our colleagues who shared their expertise on the show and generously did multiple interviews, listened to the tape, worked alongside us to make sure that we didn't sound like idiots.
And all of our friends who have been supporting us in this work. And thank you to all the listeners who've taken time to listen, give us feedback, and hopefully you'll be hearing more from us in season 2.
Yeah, I mean, it sounds like a wake, but we're keeping going.